Welcome to the Mass Department of Public Health COVID-19 Community Impact Survey on sexual orientation, gender identity, and transgender experience. My name is Sabrina Selk, and I will be guiding you through this webinar. This webinar is meant to be watched after you've already seen the COVID-19 Community Impacts Survey introduction webinar. That introduction contains important background information explaining how to interpret these results, how we did the survey, and how to frame these findings with a racial justice lens so that we can all turn the CCIS data into action. For more information, you can visit http://mass.gov/COVID survey for more information. As we begin, I would like to take a moment just to acknowledge that this was a team effort and really couldn't be done without the passion and energy of the folks listed on this slide. We also want to explicitly name our CCIS community partners, all of whom helped us recruit participants for the survey and were instrumental in us being able to show the results that we're about to discuss. We'd like to start by introducing to you a little bit about the purpose and intent of this webinar. So this webinar will share some key findings from the COVID-19 Community Impact Survey regarding the impact of the pandemic on the LGBTQ+ community. The goal is for these findings to both inform immediate as well as short-term actions, identify ways to advance new collaborative solutions with community partners to solve underlying causes of inequities, and provide data that stakeholders at every level can use to make the case for a healthy future for all. This spotlight is specifically around sexual orientation, gender identity, and transgender experience. Before we start, we'd like to recognize that these findings became public in June, which is Pride Month. The Pride Parade each year honors the Stonewall riots of 1969, led by Black transgender and non-binary activists like Marsha P. Johnson and Sylvia Rivera. Boston held its first Pride Parade 2 years later, in 1971. And since then, Massachusetts has made overall admirable progress in social, cultural, and legislative activities and advances to promote LGBTQ+ protections, including sexual orientation non-discrimination law for employment, housing, and public accommodations. However, we recognize that despite these advances and privileges in the current moment were won by the efforts and commitments of those early activists, and that we still have a long way to go. The progress that we've made has clearly not been enough. Despite the tremendous social, economic, and legal gains that have been made, we know that LGBTQ youth and adults continue to experience discrimination and stigma that causes inequities across domains. LGBT adults are more likely to earn less than $35,000, be diagnosed with depression, and be a victim of a hate crime than their cisgender heterosexual counterparts. 1 in 4 trans adults has experienced homelessness at some point, and 60% of LGBT youth felt depressed in the past year. Protections do not translate always into our practices and policies, and too many LGBT adults and youth continue to be victims of systemic violence. And since we created these slides, it's actually now 28 transgender or non-binary people have been killed by violent means nationally in the year 2021. We need to commit to continue to explicitly meet the needs of LGBT adults and youth to prevent further harm and build towards a more equitable future. Similar to the racial equity framing in the introductory webinar that discusses the role of racism as a root cause of racial and ethnic inequities, systems of oppression such as heteronormativity, heterosexism, homophobia, etc., manifest in and are perpetrated by and within the systems that determine our social determinants of health, such as healthcare, education, employment, housing. The exclusion and discrimination within these systems lead to inequities and health outcomes. These systems of oppression can manifest across multiple levels, including internalized messages about norms, whether through gender and sexuality, through interpersonal exchanges, such as bullying, family rejection, and domestic violence, in our institutions, which may not provide affirming care or may put barriers in place before care can be accessed, and also via structural means, such as folks being discriminated against in policies or through targeted legislation, such as bills that explicitly exclude people from opportunities based on their gender identity or their sexual orientation. We want to explicitly acknowledge that the frames that we use that make these conversations and understandings of data challenging. There is often a dominant frame that suggests progressive policies negate the impact of the systems of oppression we just reviewed. However, continued inequities highlight that persistent exclusion has led to inequities that have been further exacerbated by the pandemic. We need to prioritize inclusion of LGBTQA residents in all areas, including families, schools, state entities, healthcare, social services, and data systems, to aid in our recovery efforts and address underlying conditions to prevent future inequities. As we have alluded to previously, we really took an unprecedented level of participation due to our methodology to intentionally outreach to LGBTQA youth and adults with our CCIS partners, service providers, vendors, and local boards of health, including public health associations and community organizations, which has allowed us to share these experiences of the LGBTQA populations historically who've been made invisible due to small sample sizes. In addition, we were able to collect more granular data on sexual orientation and gender identity by utilizing our new DPH sexual orientation and gender identity data standards, which have supported greater granularity and visibility within this population. The pandemic has inequitably impacted LGBTQ youth and adults across multiple domains affecting the social determinants of health. We want to lift up here that even though we will talk about each domain separately, addressing any one of these domains in isolation will not work. A strategy really needs to be population-based and recognize that all of these domains are intersectional and critical if we want to reduce health inequities. One of the areas of impact for LGBTQ communities was employment. Even prior to the pandemic, LGBTQ people faced discrimination that affected the ability to attain and retain a job. Prior research shows that LGBTQ youth are more likely to experience certain risk factors that affect future employment. In the CCIS, we saw how this context influenced the pandemic's effect on employment. In the domain of paid sick leave, up to 1 in 5 or 20% of non-binary and trans adults reported not having paid sick leave. In the area of job loss, trans and non-binary adults were also more likely to experience job loss, with 1 in 5 working trans and non-binary adults reporting losing a job, compared to 1 out of 10 cisgender and male adults. We also saw impact on reduced hours and taken leave. Non-binary, bisexual, and trans adults were more likely to report needing to reduce hours or take leave than men, straight, and cisgender respondents, respectively. What can we do to address these inequities? We really need to address any gaps in sick leave benefits. Lifting up some potential solution were pulled from the Governor of Massachusetts Commission on LGBTQ Youth recommendations, which include promoting job opportunities and providing career readiness resources for LGBTQ youth. And we can do this for adults too. We also saw impacts on economic stability, and this was an area of disproportionate impact. Before the pandemic, we knew that experiences of homelessness, bullying, and discrimination affected LGBTQ youth's education and employment, impacts which can continue to affect people into adulthood. In addition, family rejection experienced by LGBTQ youth and adults can also mean people have less familial resources to draw upon in an emergency. Within our survey, we saw that LGBTQ respondents reported worry and concern about finances, with 50% of bisexual, trans, queer, and asexual and non-binary adults reporting worry about paying any bill in the next few weeks, and over 30% of trans, non-binary, asexual, bi or pansexual, and questioning adults reported worry about getting food in the next few weeks. We also saw concern about finances reported by youth. Out of those aged 18 plus who weren't sure they'd continue their education, non-binary youth were over twice as likely as males to say that this was due because of inability to pay tuition. So what can we do? Within the survey, respondents reported that access to free or cheaper food and supplies would be helpful immediately. More sustainable changes can be addressed through policy and organizational changes, such as providing LGBTQ cultural competency training to social, educational, and direct service providers in order to increase economic empowerment and stability. We also know the importance of thinking about housing, and that stable housing is needed now. Here we can see the case for the disproportionate impact of the housing crisis on this community. From earlier discussions, we know that contextual factors such as economic instability and possible family rejection or violence may put this community at increased risk for housing instability. During the pandemic, LGBTQ populations reported having two times as many worries about having to move, being 4 times as likely to worry about having to move because of inability to pay rent, and between 2 to 10 times as likely because of conflict. And youth were 2 to 5 times as likely to report violence in their household. One respondent reported, "My housemate was openly transphobic to me. They have since moved out, but the tension was at times hard to bear during the shelter in place." We also want to lift up examples of potential solutions pulling from the Governor's Massachusetts Commission on LGBTQ Youth, in this case, ensuring cultural competency of shelter staff and promoting safety and privacy of LGBTQ youth and adults in shelter settings. LGBTQ respondents also reported impacts on access to healthcare. Even before the pandemic, LGBTQ individuals experienced barriers to healthcare, such as discrimination, lack of insurance coverage, and lack of affirming care. And in the CCIS, respondents additionally reported worries about cost and insurance coverage as a barrier to receiving care. In terms of impact, bisexual, queer, transgender, and non-binary adults were more likely to report delaying any healthcare when compared to straight, cis, and male respondents, respectively. We also saw disproportionate reports of delayed sexual and reproductive health care among these groups, particularly amongst trans-identified adults. Another healthcare access point noted was around COVID testing. Out of respondents who had never been tested for COVID, LGBTQ adults were up to 6 times as likely to say that they had never been tested because they didn't know where to go. This highlights a gap in communication and outreach channels and a need for a more tailored outreach approach. To address these impacts, not only are resources such as technology needed to expand access to telehealth services, but policy changes, again lifting up the Commission on LGBTQ Youth's recommendations, are also needed. In addition to overall healthcare access, access to behavioral health services are especially critical. Violence, victimization, family rejection, and discrimination increase LGBTQ individuals' risk of needing mental and health and substance use support. Barriers to accessing this care, including prohibitive costs and discrimination, can affect this access. LGBTQ respondents reported significant mental health impacts in the CCIS. Adults were more likely to report 15 or more poor mental health days in the past 30 days, and more likely to report 3+ PTSD-like reactions to COVID. Youth, particularly non-binary and queer youth, also reported high rates of poor mental health in the past year. This data suggests that some of these impacts may have been exacerbated by the pandemic. For example, LGBTQ youth and adults reported delaying healthcare needed for stress, nervousness, anxiety, and depression. Out of trans-identified adults who reported delaying urgent care, 50% said they delayed urgent care needed for severe stress or depression. To address these impacts, mental health and substance use resources that are accessible and affirming are needed now. Training for providers on LGBTQ cultural competency is also needed on an organizational level. The pandemic also impacted social inclusion and support, areas in which inequities existed prior to the pandemic for LGBTQ individuals. LGBTQ folks may experience discrimination throughout multiple areas of their life, some of which were noted by respondents in the survey. One respondent shared being publicly targeted, harassed, and threatened due to their sexual orientation. Within the CCS, respondents reported disproportionate impacts of violence and concern for community connections. Bisexual, queer, asexual, questioning sexual orientation, and transgender and non-binary adults were up to 4 times as likely to report experiencing intimate partner violence during COVID as straight, cisgender, and male adults, respectively. LGBTQ and trans-identified youth were more likely to report experiencing violence at home during COVID, and were more likely to report being very worried about their social interactions and connections to their community than straight and cisgender youth, respectively. To address these impacts, resources are needed, including tailored social supports for LGBTQ folks, mentorship for youth, and social services for older adults. Policy and organizational efforts are also needed to effect structural change, including, as recommended by the Commission on LGBTQ Youth, changes such as the implementation of LGBTQ inclusive curricula in schools and strengthen protections against the bullying of LGBTQ youth. It's also important to remember that the LGBTQ community is not homogenous. People within the LGBTQ community experience differential impacts. Sometimes these impacts differ by sexual orientation, gender identity, and transgender experience. Sometimes these impacts differ by other characteristics and identities such as race and age. For example, transgender, non-binary, and queer adults and youth reported higher rates of certain outcomes than other LGBTQ individuals, including in areas of job loss and experience of violence. Looking at race, LGBTQ people of color were more likely to report experiences of both racism and heterosexism and homophobia. American Indian, Alaska Native, Hispanic Latinx, Black non-Hispanic non-Latinx, or multiracial or lesbian adults were also more likely to be worried about any expenses than white, gay, or lesbian adults. The intersection of age is also important. LGBTQA adults age 65 or older were more likely to report living alone than those under age 65. Gay or lesbian and questioning older adults were also more likely to request services, including social services for older adults, than straight older adults. Addressing these impacts, as noted in previous slides, requires both immediate resources to meet basic needs and address mental and behavioral health, but also more upstream strategies. If we hope to disrupt and transform the systems of oppression that have led to inequities in our health, we need to think about policy and systems level changes that are needed to address these structural determinants upstream, many of which are around increasing respectful and inclusive access to resources, capturing information on sexual orientation and gender identity to assess effectiveness of our efforts, and providing tailored resources that meet community needs. As we near the end of this presentation, I want to highlight a few key takeaways in the next two slides. These include LGBTQ plus adults and youth have been disproportionately impacted by the pandemic, particularly people of color and persons of trans experience. We need to prioritize inclusion of LGBTQ plus residents in all areas of life. This is necessary in order to support pandemic recovery, to address the conditions that contributed to these inequitable impacts and the historical impacts, and to promote optimal health and quality of life for LGBTQ plus individuals and families. We also want to note that we need to continue and create new initiatives that collect and utilize sexual orientation, gender identity data, which is critical to ensure an equitable COVID-19 recovery and prevent future harm. These results that we have laid out today clearly show that with intentional efforts, we can have enough data to look at sexual orientation, gender identity, and look within sexual orientation and gender identity to understand impact and health outcomes of this community. We also recognize and raise up that short-term resources for basic needs that are tailored for the LGBTQ plus community are needed now. This includes financial support, housing, mental health services, healthcare services, substance use services, as well as social inclusion supports. Long-term policy systems and legislative change are required to create a social environment fully inclusive of LGBTQ plus individuals. We would like to thank you for taking the time to watch this webinar and refer you to some references that might be helpful for you if you want to learn more about this important topic and what you can do to impact this community in positive ways now and into the future. If you'd like to know more about other populations or about the COVID-19 Community Impact Survey, we encourage you to visit our website at http://mass.gov/COVID survey for more information on how residents of Massachusetts have been impacted by the pandemic and how we can all work together to turn these data into action.